welcome back, everybody. This is just a little short follow-up presentation to address some of the questions and answers that weren't addressed because of the time limits in the previous webinar from Ausdent. So we're going to begin with Yao asking some questions, and then we'll change roles over. So over to you, Yao.
Okay, Laurie, the first question we have is, did I once hear you, Prof. Walsh, at a Queensland seminar say that it is theoretically possible to achieve a pH of 30 for Calmix? Or a medicament?
Well, actually, a pH of 30 is possible, but not in water. You need to go to a completely different solvent material because the pH range in water typically goes only up to about 14. But when you go into other types of liquids, and obviously we've done a lot of research into this, you can go much higher. And if you want to get around 30, then you're really looking at going towards something like ammonia as a liquid and then putting a very strong base into it. Now, that's not something you would ever want to do in dentistry, but it is technically possible, and there are entire books, several of them, written on pH in non-alkaline fluids in case you're interested in reading some more on that. It's a bit of a strange question, yeah, but it's good to sort of sort it out once and for all. Thank you.
Thanks. All right, next one. Is post-op pain more of an issue with the higher pH?
So that's a good question as well. So high pH has actually been shown to attenuate pain. So alkaline pH has been used in a number of different materials. It actually lowers pain responses. The problem is there are some materials that release very, very quickly, and sodium hydroxide or potassium hydroxide is a good example. And they're actually just chemically caustic and painful, which is a different thing from the very programmed and gradual release that happens from Calmix.
I think that's very interesting. Like I mentioned during the presentation, calcium hydroxide actually produces coagulation necrosis. And that actually, unlike you mentioned sodium hydroxide, it doesn't actually disperse very far, but it causes the so-called localized tissue effect.
That's right. And in fact, that is part of the way that it works. You've got this localized killing of bacteria, but you've also got something that generates a tissue reaction, which is a normal thing for very alkaline products or alkaline hydraulic cements, as we're often referring to them today.
Okay, moving on. What's the effect of unintentionally extruded calcium hydroxide? Would there be any concerns if a small amount is extruded?
Well, from the cytotoxicity assays which have been done, it certainly seems to be a lot less able to cause irritation in soft tissues and cytotoxicity than other types of calcium hydroxide products. You have to remember that one of the most irritating materials that we put into a tooth is sodium hypochlorite solutions, where the sodium hypochlorite itself is very much able to damage and destroy protein, but it's usually combined with a fairly large amount of sodium hydroxide, which is extremely irritant. So many extrusion reactions are actually driven from the pH and the sodium and hydroxyl ions from the sodium hydroxide. It's not so much the calcium hydroxide component, it's the sodium hydroxide that's accidentally extruded during a root canal procedure. Thanks, yeah.
Yeah, no, I'd like to just add from a clinical point of view, a lot of times if a sealer, for example, is extruded, patients will get a mild post-operative pain. I would assume it will be a similar response with calcium hydroxide, but obviously if it goes into a nerve or into a buccal space of some sort, then yes, you're going to have a lot more reaction. So the whole idea is to try and control the working length really, really well.
Yeah, exactly. Yeah, good.
Okay, next one. Does calcium hydroxide, or Calmix in particular, cause post-op pain, especially when it's extruded into the periapical region? This may be relevant when you don't use cotton pellets and you pack it in with Cavit.
Yeah, no, there's no particular evidence around it being any worse. And as I said, the data that we've got from being able to test this under controlled conditions with cell culture indicates that it's actually less cytotoxic.
Okay. The next question we have is, do you have studies comparing clinical efficiency between conventional calcium hydroxide and Calmix, such as the treatment success rates, bactericidal rates, and so on?
Yeah, it's a tricky one because it's very difficult to get anything which is a consistent type of endodontic case, and it's very difficult to do live bacterial sampling. because you often recover organisms, and if you try to grow them, you run into an interesting problem called VBNC, which means they're viable, but you can't cultivate them. And we've done some really interesting research, which we've now published on E. faecalis going into this state. So that indicates to us that unless we use the right type of analysis method, you can't easily make that sort of clinical comparison. But Calmix has been used in over 1,000 clinical cases so far, and there's no evidence that it's causing any different types of reactions when it's being used in patients. But it has become a very, very common material, mostly because of its differences in handling properties. We'll come back and talk about that a little bit more at the end of the questions to Teoh. Thanks, Teoh.
All right. Now, what are your thoughts on mixing antibiotics and calcium hydroxide?
Yeah, this question has come up quite a few times. Of course, when you take two components, A and B, and you mix them together, you end up with a diluted version of both, half A and half B. And that might reduce the efficacy, but it might give you a chance of rounding off the profile of activity. One of the challenges, though, is there any inactivation of components when you mix two things together? Because of components that are in the excipients or actually the active ingredients, if you like, battling it out or causing problems with chemical stability. A recent study on this has been done at Griffith University, for example, and it shows, not surprisingly, that if you take Calmix and you dilute it by half with another material like Letomix, then you reduce what it's doing proportional to that. It's basically a volume dilution. So whenever you're mixing materials, think about what you're trying to achieve and remember that you are diluting them one into each other.
Okay, thanks for that. The next question is Calmix safe for deciduous teeth?
Well, we know from looking at deciduous teeth in animals that it doesn't change their strength. And this is some of the work that was done by Bill Carler in his research study. There's no evidence that it weakens teeth over time, and that's why I'd be happy to leave it in a deciduous tooth. And also bear in mind that most of these teeth are going to be exfoliating around about the age of 12, if not before. So it's not a particular concern over the long term, and it certainly won't cause any physical degradation to the tooth. And that's been looked at in a number of different studies of the chemical properties of calcium hydroxide materials.
Okay. And following on from that, the next question was, does this denature the collagen?
No. So the main thing that denatures collagen inside teeth is actually the sodium hypochlorite. It's an extremely good proteolytic agent, and in the pH formulations that we use in endodontics, it's very, very good at actually breaking up the collagen structure, and this is why it is used in normal endodontic treatment. It's actually not the calcium hydroxide that is busting up the proteins, it's actually the sodium hypochlorite. So perhaps the emphasis in the question reveals that perhaps the real answer lies in a different place.
Okay, so if that's the case, would you leave Calmix permanently in the tooth?
There's a couple of situations where you might do that. One is a deciduous tooth, and the other one might be where you want to preserve a root in order to keep the alveolus or to delay an extraction so you can get an optimal timing, for example, for placing a dental implant, or you simply want to retain the alveolus and then use an overdenture. There's lots of situations where that may occur, and in my specialty of special needs dentistry, there are lots of times where we want to keep a root and stabilize it with a dome or a bollard or something like that, and that might be one option, to simply leave it with an antimicrobial material inside that we know from your research in particular, Teoh, actually resists the situation very well if the protecting dome was to be lost and it was to come into continuous exposure with saliva. It'd be, a pretty good sort of thing to have a highly alkaline material sitting inside the root canal system. But that's not what we intend. But in a general principle, long-term use, I think, certainly has some applications, yes.
Yes, and thank you. And that does tie in with Bill Kaler's research showing that, even in long-term use, it would not weaken teeth.
Yeah, exactly.
Okay. We now have a slightly different question. How do you overcome the discoloration associated with Letomix?
That's a good question, and perhaps the person who asked it knows that we've done about a dozen years of research into discoloration caused by lead mixing, including a multi-year study which has been going on for quite a few years. Fundamentally, we've explained the chemistry of lead mix discoloration in a recent paper in the European Endodontic Journal. Effectively, you need a couple of things. You need water,
Mm-hmm.
you need oxygen, and if there is light present, you also get an additional reaction which occurs. All of which means if you lose your coronal access seal and you get saliva into the lead mix, then you allow the water to enter, which puts the tetracycline into a different state and makes it more prone to a type of biodegradation, and particularly a type of oxidative degradation. And this is what actually causes the staining. If you don't do that, then the roots don't actually stain. We also know, since the classic work done by Paul Abbott many years ago, that teeth that are exposed to light for a long period of time, just ordinary sunlight, daylight, or even artificial light, they actually lighten over time. So if a tooth does go dark with lead mix, it will actually lighten over time with continued light exposure. But it's a fairly complex story, and there's basically 4 different chemical reactions that are running under the surface. So if you want to find out more, I suggest you simply look at our paper on this in the European Endodontic Journal, published recently.
Thank you. And another question. This one's regarding mixing Calmix with Leadamix paste.
Yep.
I noticed that Calmix maybe is the polyethylene glycol going somewhat harder when it is mixed with Leadamix paste. Any comments on that?
Yeah, so part of this is what you're doing to the solvent excipient, which is basically the vehicle or the carrier. So you've basically now taken a copolymer and you're mixing it with another polymer. So there's going to be a change in the viscosity, which occurs as a result of that. Remember that when we're actually preparing these copolymers, there are a number of special manufacturing techniques that are used to make sure that you can control the viscosity and the mixing proportions. If you simply just take 2 things on the bench and start mixing them together at room temperature, you're probably not going to get the ideal type of combination of the 2. So there is a viscosity change, and it's to do with the fact that you're adding a thickening agent in the form of one of the polymers. There's another reaction which can occur, and that is if you leave it out for a long time, you may actually get some calcium carbonate formation as environmental carbon dioxide starts to interact with the calcium hydroxide sitting on the surface. But that would take a long time to occur, and that's probably not a big contributor. It's mostly just the thickening reaction. Okay, so I think we're going to ask you some questions, yeah? So spread the love around. So I want to talk a little bit about vital pulp therapy. So if you had a traumatized anterior tooth and it's going to need a direct pulp cap, what sort of material would you use? Would it be some type of alkaline cement? Would it be pure calcium hydroxide that you'd mix up from a powder? Would it be a material like Calmix? What would you use and why?
As I mentioned during the presentation, I think the biology or the understanding of vital pulp therapy is more important today than the actual material itself. So the whole understanding of vital pulp therapy is complete caries removal. We've sort of gone towards the point where selective caries removal leaves behind remnant caries which can continue to cause symptoms within the pulp. So the whole idea behind it is to remove all the remnant bacteria and allow the body to actually heal itself. So if that's the case, the medicament is sort of used as an adjunct just to help the body repair itself. So the idea is to have something that is both antibacterial, but something that also seals really well. So from that point of view, I mean, it's good to have a material that seals well and antibacterial. And at the moment, I think MTA solves that problem. But the biggest issue with MTA is it does stain. Not all MTAs are white variants, and in interior teeth, aesthetics is a big component of the treatment plan. So because of that, I tend to personally go to Calmix and I cover it with a bit of flowable, or you can use Vitribond, which is self-etching. Alternatively, you can use a non-staining MTA variant, such as Biodentine. I'm not too familiar with Theracal, but I do believe it is a mixture between calcium hydroxide and flowable resin. But that does bring about some problems as well, because Theracal can actually, with the flowable resin, stop the release of calcium hydroxide. So that's something that we do need to explore a bit further in future research.
So if you were doing that technique, how does the material that you stick on top of the calcium hydroxide just sit there passively? Does it bond to it in any way?
Well, technically, you can't bond to it. I mean, the calcium hydroxide, it's going to be it's going to be left in place, usually to cover the pulp exposure. And then I would put a bit of flowable resin just over the top. Yes, it will not bond very, very strongly, but the whole idea is so that we can protect the resin, protect the calcium hydroxide, and then we can actually etch the entire cavity. So it's no different from leaving a medicated liner that is not physically bonding to the tooth. It's just trying to seal an area so that we don't wash it out, and then after that we can actually cover the entire tooth or the entire cavity with something that's more permanent. But in these cases, I have used Vitrabond, which it is self-etching, and it does adhere pretty well to dentine.
Yeah. And would you be using etch on the tooth before you put your calcium hydroxide on, or not?
I don't think there is going to be much difference in whether you etch before or after, but usually because of the bleeding that's happening, and we've gone through all these steps to try and control the bleeding, usually with a hypochlorite soaked palette, I don't want to disrupt everything, because if you put etch in there, you will have to flush it up with water again. So with the hypochlorite, I can lightly irrigate with just a bit of saline or water, and then that way I like to put my calcium hydroxide, get it all stable, and then once you've got your flowable or Vitrabond over, which is covering and protecting it, then you can go about rinsing it and actually drying the cavity as you please.
And in a situation where there was trauma, let's say, someone's injured their central incisor in a bicycle accident or something like that. So you're thinking about materials to put on. Is there any value in mixing a steroid antibiotic paste like Letomix with the calcium hydroxide paste like the Calmix, or do you just simply go for one or for the other in that sort of trauma situation?
I think it depends on the situation, if the tooth is vital or not. There is, if we are trying to maintain vitality of the tooth, and you're trying to keep the tooth, and you're trying to do vital pulp therapy per se, then yes, I would just use calcium hydroxide, because the whole idea is we are trying to create a sterile environment and to produce an environment where the pulp will lay down new mineralized tissue to sort of seal off this this gap or this exposure. In the event that the tooth is necrotic, and if it's an immature tooth that we're trying to achieve apexification, then by that means we do want calcium hydroxide there, because you do want calcium hydroxide to give you an antibacterial effect, but at the same time, calcium hydroxide also has been shown to be caustic. So it does erode a bit of the dentinal walls, and that releases growth factors that actually stimulate apexification. So how Letomix ties into this, I don't see how that really comes into the picture unless you really need some immediate pain relief. So you can, if you're going to go ahead with the root canal treatment on the first visit, then yes, a mixture of calcium hydroxide and Letomix paste, as what Professor Paul Abbott has done over many, many years, you can do that for the first stage. But towards the later stages, you do go back to a calcium hydroxide solely as the medicament, because you do want to get that effect of antibacterial, and at the same time, to initiate hard tissue formation.
Yeah, so that's the reason you wouldn't use the cement form of Letomix for direct pulp capping either, because it's a very different formulation with Zoe in it. So, yeah.
Exactly. And zinc oxide eugenol is also a tissue irritant. So it's something that you don't want to aggravate the pulp further. The whole idea is to try and keep it as a sterile environment and to actually help induce hard tissue formation. So you want to put anything that is biologically compatible.
Yeah, it's always a good thing for practitioners to have on reference the IADT trauma management document, because it's just a really good way of just saying, in this situation, do this and do that. So those things are exactly in line with that. Let's now sort of move on and talk about cases where patients have got pain. So when we're thinking about, when someone's got, an acutely presenting pain, and you're thinking about, do they need a corticosteroid in the form of Letomix, for example, or are we going to rely on the fact that we're removing most of the bacterial products and therefore it's going to die down, and maybe the calcium hydroxide will swamp that a bit more. Which sort of way would you go when you've got a patient who's in pain and you're going to do an extirpation and you're thinking, what will I put in as the intervisit dressing?
That is a good question. And I think it really also comes down to the clinical situation. Let's start with a vital tooth. If you've got a hot pulp per se, in these cases, if I can remove the entire pulp, including down to the root canals, then I don't see any reason why you can't use calcium hydroxide, because you get additional antibacterial effects. At the same time, as you mentioned earlier, the rise in pH actually reduces pain. But if you're going in and you're just purely doing an extirpation within the pulp chamber and you haven't actually gone down the root canals, then I'd probably look at putting in some sort of a steroidal paste, because you do want some pain relief. But do bear in mind that steroidal paste don't really have a lot of antibacterial effects. As we mentioned in the presentation, antibiotics, they are good, but they don't kill bacteria indiscriminately. So because of that, they are good to relieve pain for a short term, but to me, it all comes down to how much time I have. If I can remove the pulp completely, I would put calcium hydroxide. And if I can't, and if it's just purely going in just to relieve pain, then I would use some sort of steroidal paste. But at the same time, you can always do a 50-50 mix in these kind of cases. In the event that the tooth is non-vital, then I would always try to open the canals a little bit, because you're trying to remove as much bacteria as possible, try to reduce the bioburden within the canal system. And I'd definitely be using a calcium hydroxide paste, because we are trying to remove bacteria or trying to reduce the amount of bacterial load in the canals. At that point, I don't really see much use of a corticosteroid paste.
So in that situation, would you find more of the contamination and bacteria in the coronal third or in the apical third?
In a vital tooth, with a hot pulp, like a symptomatic irreversible pulpitis case, majority of the bacteria is usually in the coronal third. I mean, it hasn't made its way to the apex of the tooth. You can have endotoxins from bacteria that do travel ahead of the bacteria, and that may give you your symptoms such as your tenderness to percussion, but majority of the bacteria is actually congregated at the in the pulp chamber. And if we look at it histologically, and the paper that I put up, which you guys have the slides to, Domenico Riccucci did a lot of histology slides on all these vital cases, but with irreversible pulpitis as a symptom. And they found that, necrosis happens in pockets. So you've got little focus or foci of infection going on, and not necessarily coagulating and infecting the entire thing. And that's the reason why our understanding today of vital pulp therapy is so important, that, it is the removal of bacteria completely and necrotic tissues that gives you success.
Yep. So in terms of what you're going to do at the end of a procedure, how many days would you normally leave the calcium hydroxide paste in the root canal to try to get the most effectiveness from it? Is that a matter of days? Is it weeks? Or is it longer than that? What do you think?
In a non-vital case, the whole idea is for the calcium hydroxide to slowly work its magic to actually kill the bacteria. Classic clinical studies advocate a 1-week turnaround. From our studies that we've done together, I think about a 1 week is the point where you actually start to see some significant changes. But the beauty of Calmix is that it actually maintains this high pH for as long as 3 weeks. Now, it can probably maintain much further than that, but our studies show that, we stopped it at about the 3-week mark. So I'd say that, anywhere from 1 week to a month is about right.
So how would you make a decision around redressing? Let's say, for example, you notice radiographically there appears to be a moderately sized cystic lesion. Would that be a trigger to replace or replenish that calcium hydroxide or not?
My decision to obturate the tooth usually depends on the symptoms. If the clinical symptoms have resolved itself, and I can actually dry the canals, The problem with cystic lesions is sometimes there's a fair bit of exudate that you can't actually dry the canals predictably, and it starts to seep into the canal slowly just before you obturate. If that tends to happen, I would keep dressing until I can dry the canals, and probably wait a few minutes after you dry them and check them to make sure that it's actually dry. If I can do that, then I think we've done our job. The pain has gone away. The canals can be dried. There's no reason why we can't obturate, because the body will start to heal itself over time. What's outside of the root canal, really, it's just dependent on our immune system to heal the periapical tissues. Now, if we have a case where there is a big cystic lesion and it's non-healing, I think redressing multiple times may help. But in some cases, we might have to look at other treatments such as surgical resection of some sort. So in these kind of cases, I tend to treat the symptoms. If the tooth is asymptomatic, I can dry the tooth, I'd obturate it. But if it's a big lesion, I tend to leave it for at least 2 weeks, because I know that that's the time it takes to really give me good disinfection. And at the same time, it sort of gives me enough time enough time for the patient to actually come back and feel more comfortable, and we'll actually finish the case off.
Good. So the last couple of questions are ones that are just purely clinical application ones. So how do you know if you're dispensing the right amount of material? For example, if you use the little tiny microtips, aren't you worried about extruding it out the end, or underfilling? How do you know that you're basically doing it right?
I tend to measure the microtips, because they look like little flowable tips with a little extension that it's flexible. In that little metal bit where it appears like a flowable tip, I tend to kink it a little bit so I can measure it accurately, and then I put it into the canals and I backfill it. Now, when you backfill it, do it slowly. Don't pump it out really quickly, and look for the backflow. That way, I know that I'm not extruding it out the apex, and I slowly withdraw the syringe. There are times where it is difficult to get to the apex. Once I'm done with that, I do put a file in there and just turn it counterclockwise. That way, I get to working length, and as I turn counterclockwise, it leaves a trail behind. Alternatively, you can use a paper point or a small GP cone to try and push the calcium hydroxide down. The whole idea is try not to use anything, whether it is the syringe or the microchip or the GP point. Try not to have a pumping action, because that tends to extrude calcium hydroxide out the end. And I think with the rubber dam still on, take a quick X-ray. We know that this material is highly radio opaque, especially with anterior teeth, where I need the calcium hydroxide right at the apex. If you want to achieve good disinfection and you're trying to induce apexification, I'll take a quick X-ray. And if I can see the calcium hydroxide there, then I temporize. If not, I'll go back in and put a little bit more.
Excellent. Thanks. That's great clinical advice. Very, very practical. Well, I hope we've been able to answer the questions. The fact that we got almost as much discussion points as we did give a presentation indicates that people have obviously thought a lot about the topic. So once again, thank you for your involvement in our webinar, and we hope these questions have expanded on the material that we originally presented to you. Thank you very much.